And another question, Professor Lee, while the vision is inspiring, implementation is challenging. From academic advocacy in top hospitals to grassroots prevention, what is the most difficult barrier to making pan-vascular care accessible to ordinary people? Is it technology, awareness, or structural healthcare system issues?
In different hospitals, they have different barriers. But for me, I think the doctor's awareness for treat the patient systemically, and also the structure of the health system is a two major barrier. As I explained before, I have already explained before, in our hospital, we have already got MDT, but I think in the future, we could have the other MDTs. For example, we should have MDT for the valvular heart disease, for the end-stage heart failure, for the patient with pan-vascular disease. We have a lot of patients like that. But if the patient go to each specialist, they go to cardiologist, okay, I just treat the heart. If the patient has maybe some peripheral artery disease, I said, okay, sorry, I don't have enough time. You go to my college vascular surgeon, he will give you more advice. Maybe in the future, we should have a system. For example, we don't just we unite together. We go to the outpatient clinic together. Maybe in the future, we can put the patient in the ward together. So each patient, when they go to the hospital, no matter for outpatient clinic or when he admitted in the hospital, he can get the doctor's advice from all aspects. I think we should try to push the structure of the health well-being. Yeah. That's my perspective.
Thank you, Dr. Professor Lee. And sounds like that MDT is a very efficient way in China to solve the problem. So, Dr. Professor Cooke, what progress has the U.S. made in integrating pan-vascular care, and what obstacles have you encountered?
Yeah.
So, are there any key lessons worth sharing?
Yeah, absolutely. One of the issues is just awareness and education for the physicians. And so at our DeBakey Heart and Vascular Center, we have the cardiovascular surgeons and cardiovascular doctors working together, cardiac surgery, cardiovascular medicine. We work together in the DeBakey Heart and Vascular Center, and we share education. So we have regular grand rounds. We have many seminars. We also have something for the general audience, medical audience, on YouTube, the DeBakey Heart and Vascular YouTube, which has hundreds of wonderful lectures, from our grand rounds and our seminars. So part of the problem can be solved by education. If I know what you're doing and what you can do as an interventionalist, if you know how I'm treating my vascular patients, we start to share information and we build a practice that is better.
Yeah.
So that's part of it. And then also another way to solve the issue, which you touched on, Dr. Lee, was to bring together people physically in a structure where they are working together, in clinics where they are working together. One of the unifying clinics that we have in the DeBakey Heart and Vascular Center is our preventive medicine, because anyone that sees a vascular surgeon or a cardiologist needs to see a preventive doctor to get care for their risk factors. And if I can, maybe if I can move on to another unifying theory that's going to integrate cardiovascular medicine is vascular aging as a process that is modifiable. And maybe if there's time a little bit later in the show, we can talk about that.
Allow me to share with you a real case of the MDT, the strength of MDT. I think it's about maybe 5 or maybe 6 years ago. 6 years ago, it's before the pandemic. 6 years ago, one very young girl, about 25 years old or something like that, she got a cardiogenic shock. Initially, he go to the vascular surgeon, the cardiothoracic surgeon. I don't know why he go to the surgeon. The surgeon suspect he has an aortic dissection, but they find the patient had a very tight left main. The left main coronary is almost occluded.
Wow.
But he's very strange. He's only about 25 years old. He's a very young lady.
Yeah.
So The lady was transferred to our hospital. On the second day of his arrival, because he arrived late, I do the coronary intervention for her, and it's revealed the almost occluded left main coronary artery. I wire the lesion and then just open it and do a intravascular ultrasound. But it's not real. The coronary is absolutely normal, but thickened at the aortic root. So anyway, just stand to the left main and put the patient back to the ward. When I come back to the patient ward, I ask the echocardiologist to check the patient subarachnoid artery, brachial artery, radial artery, find some tiny thickening at the different points. So I asked the rheumatologist, how do you think about the patient? Arthritis. So we don't have enough evidence. When the patient was recovered, I sent her for a PET scan, found multiple hypermetabolism at the iliac artery, brachial artery, or some multiple hypermetabolism.
Yeah, right.
So I sent the rheumatologist to follow up. He just come to me once a year, and then my rheumatologist colleagues treated the patient. And last week, 2 weeks before, gynecologist asked me for help because she wants to have her baby. So I talked with my gynecologist colleagues, and I'm lucky because last morning I was told that she had her baby.
Nice.
Yeah.
And a wonderful story.
Yeah, it's a very excellent example for treat the vascular disease with the MDT.
Yeah. Nice.
Yes.
Nice story.
你好，中国，东方问道。